Welcome to the San Diego Liver Coalition Q&A webinar and Global Fatty Liver Day discussion panel. My name is Chaplain Dr. Neshea Harrison, and I am the board president of the Liver Coalition of San Diego. Tonight, we will be bringing together medical experts, public health leaders, community advocates, and a patient advocate to discuss one of the fastest growing health challenges known as MASLD. Many of you have heard of MASLD. Nearly 38% of US adults are affected. The good news is that early detection, lifestyle changes, access to care, and community support can be a tremendous difference. Our goal here tonight is simple: educate, empower, and inspire. So thank you so much for joining us. Tonight, our first speaker is Dr. Mónica Tincopa. It is my pleasure to introduce her. She is the Assistant Professor of Medicine and Transplant Hepatology at UC San Diego School of Medicine. She's an investigator with the UC San Diego MASLD Research Center and co-founder of Latinos in Gastroenterology and Hepatology. So please join me in welcoming Dr. Mónica Tincopa.
Thank you so much for this opportunity to chat with you guys today. I'm going to attempt to share my screen, and you guys can let me know if you can see it once I have it in the correct. Can you see that correctly? Is it the right?
Yes.
Okay, fantastic, great. So thank you again. I think I have roughly about 40 minutes to go through this talk, and then I believe at the end of this we'll have a time for questions, answers, and discussion. So I was tasked with going over this topic: understanding, identifying, managing, and managing MASLD and MASH. And as we had stated, today is Global Fatty Liver Day, so we really wanted to bring a lot of kind of attention and discussion to this specifically today. As I mentioned, I am at the University of California, San Diego. I am a transplant hepatologist and clinical researcher, so I work in our MASLD Research Center here at UC San Diego. These are my disclosures. So I like to provide a roadmap just so we know what different points we're going to touch on, and again, this can help think of different questions you may have for the purpose of the discussion. And I know we have a broad audience today, so I think it's always important to start with just kind of defining what MASLD and MASH is. It can be a lot of alphabet soup. Particularly over the past few years where we've transitioned from the old terminology we used to use to the current terminology, so I'll go over that. Really want to highlight, why are we talking about this today? Why is there an entire day dedicated just to fatty liver disease? So how common is MASLD? Who are the individuals that are at risk for it? Who should we be thinking about screening? Then to really go over what's the natural history of this condition, how does it present, what can happen, why is this such an important problem, and why is it really a public health crisis? From there to go on to, well, how do we screen for it? How do we risk stratify patients? Essentially, how do we find people who have this condition? Because we know that the vast majority of people who have fatty liver disease actually are not diagnosed with it. From there to transition to the very exciting time that we're in. You know, for many, many years, we had no treatments specifically to offer beyond lifestyle interventions, but to highlight what's available now, what seems to be on the horizon, and how do we really manage patients once they get diagnosed with this. And then to close on kind of what are the unmet needs, where do we go from here? So as I said, there is a lot of different acronyms, terminology. As you may or may not be aware, this used to be called non-alcoholic fatty liver disease, or NAFLD. The other term was NASH, non-alcoholic steatohepatitis. And as of 2023, we transitioned. So now this is referred to as metabolic dysfunction associated steatotic liver disease, or MASLD. Why did we change the terminology? Well, there were several key reasons. So some of the limitations of the prior terminology was it was non-alcoholic, so it really was an exclusionary diagnosis, and a lot of kind of providers and patients found this both confusing and challenging. The other major push for changing the terminology was really the stigmatizing nature of the disease name. So both the use of the term alcoholic and also use of the term fatty. And so they wanted to kind of shy away from that and use terminology that wasn't as stigmatizing. The other main reason that we changed the terminology and kind of created new categories is in the setting of the current public health status, there is both a high prevalence of obesity and metabolic syndrome, but also a high prevalence of both alcohol use disorder, but individuals also who may not have alcohol use disorder but have very regular alcohol intake. And in the past, we didn't know what to do with these individuals. Did it make sense to categorize them as MASLD? Were they more of an alcohol-associated liver disease? There was no what we call overlap category, and that has changed with this change in terminology. So now there's a new umbrella term called steatotic liver disease. What does that mean? So essentially it means that there is a broad category of liver conditions that is defined by the presence of fat buildup or hepatic steatosis in the liver. So this can be detected either by imaging or in the small percentage of patients who actually have a biopsy. So that's the umbrella term, and in terms of kind of going down this flow chart to figure out which of the three categories people may fall into, the initial question is, does an individual have any cardiometabolic criteria? And in a subsequent slide, I'll go over what those are. And depending on the answer to that question, that will help kind of further branch this out. So if the individual has hepatic steatosis or fat buildup, and they have cardiometabolic criteria, then you have to say, okay, are there any other potential causes of fat buildup in the liver? The main one being regular alcohol use. If that is no, then they fit into the definition of MASLD or metabolic dysfunction associated steatotic liver disease. If, on the other hand, they don't have any cardiometabolic criteria and they have regular alcohol use, then you're going down the other side of this flow diagram where we're talking about alcohol associated liver disease. And this goes over what those cardiometabolic criteria are. So for people who work in primary care or who are familiar with metabolic syndrome, essentially these are the components of metabolic syndrome. The difference compared to metabolic syndrome is you only actually have to have one out of any of these 5 criteria to say, okay, you meet the definition for MASLD. Those include body mass index. So generally speaking, 25 or higher, although there is some nuance here. Because there are specific lower cut points in populations that tend to develop fatty liver at lower BMIs, particularly individuals from different parts of Asia. You can technically also meet criteria based on waist circumference, although the vast majority of individuals don't get their waist measured as part of their clinical care. The second criteria is any evidence of impaired glucose. So whether you actually have a fasting serum glucose done, you have a diagnosis of type 2 diabetes, or you have an hemoglobin A1C above 5.7. An individual who has hypertension or is on antihypertensive medications. Somebody who may have elevated plasma triglycerides, or anyone who is already on statin therapy. And then the last one is having low HDL or low good cholesterol, or again, whether or not you're on statin therapy. So these are all of the different criteria that we look at, and again, you only need one out of any of these 5. And again, going back to our flow diagram here, the overarching term being steatotic liver disease. Depending on if you have cardiometabolic criteria and what your alcohol intake is, it puts you into these categories. Now again, I said the new other thing is this overlap category that we call MET ALD, essentially the MET representing metabolic syndrome and ALD for alcohol-associated liver disease. And essentially this is a spectrum. This can be difficult to kind of accurately say yes or no somebody falls in this category. Why? The reason for that is the way that we define this is based off of weekly or average daily alcohol intake as defined by grams of alcohol. As you can imagine, the vast majority of people don't really track their grams of alcohol either by week or by day. And we know there's a whole other kind of discussion just about how do you accurately assess alcohol intake. But people are also not really good at being able to assess kind of what is their average alcohol intake, mostly because standard drinks, particularly if you're pouring your own drinks at home, people don't strictly follow that. So this can be challenging, but in gross terms, if your average daily alcohol intake in grams is 20 to 30 or 50 to 60, the difference is slightly lower in females compared to males. That just has to be is a reflection of the biologic difference in terms of the level of alcohol intake in which we see liver damage. But if you fall within this range and you have cardiometabolic criteria, then you're in this new overlap category. So again, going more into the detail about how do you know kind of more definitively if somebody has MASLD. So this kind of graphically shows if you had a healthy liver and you were to do a liver biopsy, what that would look like. So here you see these kind of reddish pink cells. It looks very healthy, nothing else there. Compared that to somebody who has fat buildup or steatosis in the liver. So you see the liver cells and kind of in between them, this yellow buildup of fat cells in the liver. So again, if you were to do a biopsy, this is what you would see. So by definition, somebody has to have at least 5% buildup of fat in the liver, and again, an absence of any other secondary causes. As I said, the main one, the most common one, is significant alcohol consumption, and these are the cut points, again, if you define it by grams of alcohol per day. The other thing that is really important to do is to do a good medication review, because the other common reason that people can have fat buildup in the liver is medications. So what are the medications? By far and away, the most common ones that we see are people who either regularly or chronically are on corticosteroids, so if they have autoimmune conditions, pulmonary conditions, etc. Other common medications, amiodarone can do it, methotrexate can do it. For our patients with a history of breast cancer, tamoxifen can do it. Anti-seizure medications, and then other chemotherapy agents. So again, if it's a new diagnosis, you're working somebody up, you want to make sure you do a good medication review. Kind of on the opposite end of the spectrum, this is a much more rare cause, but patients who have poor nutrition, so kind of more in a starvation mode if they're chronically on TPN, and then these rare genetic disorders, again, much less common, but technically part of your evaluation process to make sure there's nothing else that could be contributing to fat buildup in the liver. So of everyone who has fatty liver disease or MASLD, there is a subset of individuals that have the more aggressive form. Again, this used to be termed NASH. Now that is MASH, or metabolic dysfunction associated steatohepatitis. So what does that mean? So if you see here on the left of this figure, somebody had a biopsy, they have MASLD. So they have the fat buildup in the liver, but really no other evidence of liver cell damage. So 80% of individuals will have kind of what we call simple steatosis without direct liver cell damage. 20% of individuals will have the more aggressive form of fatty liver disease called MASH. So they have the 5% buildup of fat, but they also have evidence of inflammation and direct liver cell damage with the development of scar tissue or fibrosis. Technically speaking, this is still a diagnosis made off of liver biopsy, although in clinical practice, most people don't have biopsy. We can say based off of their labs and other imaging tests that they likely have this more aggressive subtype. And again, 80% have simple steatosis or MASLD, 20% have the more progressive form, and it's these people who have the more progressive form who ultimately can develop significant scarring of the liver and can develop cirrhosis. So these are the people that we're worried about, and these are the people that we're trying to find out kind of in clinical practice and in the community. So you heard a little bit about this at the beginning of the talk, but unfortunately MASLD is a super common problem, both in the US and worldwide. So this is an infographic from a paper published now in 2023, but you can see the estimates in North America is approximately 31% of all adults in the United States have MASLD. And then you can see across the globe, the prevalence varies a little bit, but you can see kind of in neighboring Latin America as high as 45% of individuals. So a super common problem worldwide. However, the prevalence highly variable depending on individual risk factors. So individuals who have class 3 obesity, up to 85% of those individuals will have MASLD. Type 2 diabetes, the cited rates are a little bit variable, anywhere from 30 to 75% individuals, so tons of patients being followed in an endocrinology clinic. Metabolic syndrome, about half of individuals have it. From a biologic sex perspective, it's interesting. So premenopausal, it's more common in males, but actually in the postmenopausal era, it's actually much more common in females. So we end up seeing a lot of females in clinic kind of in the postmenopausal phase, particularly those considering hormone replacement therapy, who have a lot of difficulty with weight loss, and they end up getting diagnosed with MASLD. And then super relevant to anyone in California, particularly in San Diego. Very, very, very high prevalence in the Hispanic and Latino population, so anywhere between 45 to 50%. We actually do a lot of work in this area just because it's such a common problem in this population. This goes a little bit more into that. So this initial figure here is looking kind of more globally across all forms of liver disease, and you can see when they analyze the United States, the entire state of California is a hot spot for high rates of liver-related mortality. So huge problem here. And then this is a study we published a few years ago now where we looked at all of the published literature and said, okay, in the updated kind of era of rates of obesity, what is the prevalence of and relative risk of developing MASLD and MASH in the Hispanic population? And what we found was that Hispanic adults have a relative risk of 1.5 of developing MASLD and 1.4 for developing the more aggressive subtype or MASH. So much higher risk of developing these conditions in that patient population. We know that MASLD develops earlier, progresses faster, is associated with a higher rate of liver cancer, which is what HCC stands for, higher need for liver transplantation, and overall higher rates of liver-related mortality in Hispanic adults. So a little bit about the natural history. I touched on this slightly prior in one of the slides, but again, if we take a step back and we say 30% of all adults in the U.S. have MASLD, it's a huge number of patients. You know, it wasn't until actually a few years ago that there were society recommendations to start screening for MASLD, in part because it was so prevalent, and the other part was up until a few years ago, we actually didn't have any specific prescription medications to treat this. It was just kind of general recommendations to eat healthy, lose weight, and optimize your metabolic conditions. That's changed, and so now there are screening recommendations, which we'll get into, but in part it's because part of the difficulty is that of everyone who has MASLD, actually only 20% have the more aggressive form, as we talked about, MASH. Of everyone who has MASH, only 20% of those people at the end of the day will develop cirrhosis. So even though it's a super common problem, only a small percentage of those patients will end up having end-stage liver disease as their main issue. I don't have a specific slide on this, but as you can imagine, because of the risk factors for developing this condition, the leading cause of death in adults who have MASLD actually is cardiovascular, as you can imagine, because you have risk factors for developing heart disease. The second leading cause of death in adults with MASLD is actually cancer. And the reason we think that is because these risk factors also increase risks of kind of more common causes of cancer. And then it's not until you get to the third leading cause of death that it's actually liver related. The other challenge is there's really a non-linear disease progression. So people can have MASLD for years and then all of a sudden have a very rapid progression in their liver disease. So this is a little bit hard to know exactly what the rate of progression is, but for the most part we think you can increase one stage of scarring over 7 years in people who have MASH, and one stage actually over 14 years in people who have kind of MASLD. So again, very slowly progressive disease. But the issue is most people don't know that they have it, so they don't present to care until they get to the point where they're needing a liver transplantation, at which point we've really missed our opportunity to help patients. The other challenge is people can develop liver cancer in MASH even if you don't have cirrhosis. Generally, we only do screening for liver cancer in people who have cirrhosis unless you have viral hepatitis B. But again, there is a risk to develop this even if you don't have cirrhosis. So sometimes people present to our clinic with a new diagnosis of liver cancer, having never known that they had liver disease from fatty liver disease previously. So the key thing that we really try to focus on is trying to get a good sense of who are the individuals that have already accrued liver cell damage, scarring, or fibrosis. The reason we really focus on that is we know that fibrosis stage, or the amount of scarring, predicts your risk of dying in this condition. So this is a figure that you'll see all the time in talks about fatty liver disease, and we know that both overall rates of risk of overall rates of dying and liver-related mortality, or dying from a liver-related cause in this condition, is directly related to your amount of scarring. So the way that we grade scarring, 0 means none, you have no scarring in the liver, 4 means you have scarring throughout the liver, or you have cirrhosis. And the point where the risk really increases is at stage 2. So we are trying to identify individuals who have stage 2 scarring or higher, because those are the individuals that are going to run into trouble. So there's a specific entity that we call at-risk MASH, again, MASH being the more aggressive form of liver disease, because we know those are the individuals that are at the highest risk of having bad outcomes. So again, technically speaking, to diagnose MASH, you have to have a liver biopsy, but that by other measures means that we're worried that somebody has inflammation and liver cell damage. And then again, looking for the stage 2 fibrosis or higher. From another clinical perspective, this is also super important because we've really seen a dramatic change in the number of people needing liver transplant and the reasons that they need liver transplant. So what we're trying to highlight in these figures here, you know, each of the different lines and dots represent a different form of chronic liver disease. In the past, the vast majority of people who needed a liver transplant were from viral hepatitis. Thankfully, we have great treatments for hepatitis C now, and so that's really dropped off. And what we see is the leading and kind of competing reasons that people need transplant are either from MASLD, or fatty liver disease, or from alcohol-associated liver disease. So it's really dramatically changed who's getting referred and who is needing liver transplantation. So essentially, MASLD is on par or equal to alcohol, and actually it's the leading reason for liver transplantation in females and in individuals age 65 and higher. So how do people present? How do we kind of case find, figure out who needs to see us? Well, as I mentioned, one of the huge challenges here is, by and large, this is an asymptomatic condition. People have no symptoms. Most people do not know that they have this, and so they present very late in the course. There are some individuals who will kind of report this non-specific discomfort or pain in their right upper quadrant, or they'll report fatigue, but as you can imagine, fatigue is a very non-specific symptom, so it doesn't automatically make you worried about having to screen for liver disease. A lot of primary care physicians will start doing a workup for liver disease if somebody has elevated liver enzymes. But a key point to know is that liver enzymes can actually be normal in anywhere between 30 to 60% of individuals who have this condition, so it is not a good way to screen, and it should not necessarily be reassuring if the liver labs are normal, because that doesn't mean that you may not have this condition. So a very common way that people end up kind of started getting evaluated for this is they'll have imaging for some other reason. Say they had abdominal pain or they had back pain and they were being worked up for like a kidney stone. So on an ultrasound or a CAT scan, they'll kind of incidentally be noted to have fat buildup in the liver, and then this will start a workup for the patient. So if you were to get a liver ultrasound, which is the most common way that we initially screen for this, this is potentially what it would look like. So on the left-hand side, you see a normal liver. It's kind of dark. Whereas on the right-hand side, it's bright. And so this is a way that we can see, okay, this person likely has a lot of fat buildup in the liver. There are other imaging tests that you can do, and this just kind of lists, you know, depending on what test you do, how good of a test it is to pick up fat buildup in the liver. Outside of a biopsy, actually the most accurate test is an MRI, but as you can imagine, it's much more expensive, and most people don't get an MRI. But by far and away, ultrasound is usually the initial test we do to say, okay, is there any evidence of fat buildup in the liver? How do we screen people? So as I said, there didn't used to be recommendations to screen. Now that we have treatments to offer, this is the recommendation from our American Liver Society, or AASLD. So this is kind of the flow diagram through which it's recommended for kind of primary care providers and other specialists who may be seeing these patients, like I said, endocrinology, cardiology, potentially, in terms of who we should be thinking about. So again, anyone who has cardiometabolic risk factors, if somebody had imaging for whatever reason and they were found to have fat buildup in the liver, a lot of times people do start getting a workup if they have elevated liver enzymes. But the first risk stratification test to see if somebody potentially has developed scarring in the liver is this test called a FIB-4. A FIB-4 is a calculation based off of routinely obtained blood tests. And once you get that, you can get this calculation. And this calculation essentially will put you into one of three buckets: low risk, intermediate or indeterminate, or high risk. And essentially, anyone who has an intermediate or high risk test then has to go on to additional testing. If it's very high number, so the cut point to remember here is 2.67, most of the time people will just then be referred on to see a GI or liver specialist. Not all the time, but most of the time. If you have a FIB4 between 1.3 and 2.67, then usually people will do a secondary test. That secondary test can either be another imaging test called a FibroScan, or VCTE is the abbreviation. How available that is to primary care and patients is variable. So some communities, there's multiple different places you can do it. If you practice in a rural setting or other settings, you may not have access to that, so it's not always a great option. The other secondary test is another blood test, although it's a send-out test. That's called an ELF test, but it's essentially a blood test. And again, whether you order a FibroScan or the ELF test, in this figure here, you can see it will put you into different buckets: low, medium, or high risk. Depending, if you're low risk, you can go back and stay in primary care and they'll continue to follow you depending on your risk factors. Usually they'll say do another FIB4 in 1 to 2 years. If you're intermediate to high risk, again, then these are the patients that we recommend go to see either a GI or liver specialist to figure out what to do from there. So this is a little bit more about that FibroScan or VCTE. VCTE stands for Vibration Controlled Transient Elastography. But essentially this is a fancy ultrasound. On the ultrasound probe, there's a little part of it that kind of goes in and out and creates this vibration, with the thought being that as the liver gets more scar tissue, the liver becomes more and more stiff. And so this ultrasound probe will measure the stiffness of the liver. So the stiffer the liver is, the more concern you have that somebody has a lot of scar tissue buildup. This is a great test. It's a fast test. Again, how available it is highly variable depending on where you practice and where you live. The issue with this test is there's a number of different factors that can impact how accurate it is. So in order to do the test, you have to be fasting. If somebody has eaten recently, that can sometimes falsely elevate the reading. So you have to make sure that as you're scheduling patients for this, that they know about that. But the other reasons listed here in this box are the other kind of challenges that can sometimes make this an unreliable test. So if somebody has a lot of inflammation in the liver, so if their ALT, which is one of your liver tests, is above 100, again, you may have a false elevation in the stiffness because active inflammation can make the stiffness measurement high. The other real challenge here is as you get more and more subcutaneous fat tissue, so as your BMI goes up, your stiffness measurement may also go up. And that just has to do with how far away the ultrasound probe is from the actual measurement of what it's trying to measure. So as you can imagine, elevated BMI is one of the risk factors for this condition. So a lot of patients that we're screening and risk stratifying have an elevated BMI. So if you're ordering this test on somebody who has a very high BMI, this may not give you an accurate test. It may be helpful if it's low, but if it's high, I don't know if it's high because it just wasn't a great test to order for this patient or because they have a lot of scar tissue development. So there is something else, another imaging test that is non-invasive, that is much more accurate to do a liver stiffness assessment. That's called an MR elastography, or MRE. The problem with this, again, it's MRI, so it's a lot more expensive. This also is really only done at large academic medical centers, so access is an issue. But unlike the FibroScan that really only assesses one point of the liver, this will give you a 2D mapping of the liver, and so that's what these images are showing. So you can get one part of information which is called a PDFF, or proton density fat fraction, which will give you a heat map of fat buildup. And so that's what this is showing here, here in this bottom picture. So as you get to the red, that will tell you what percentage of fat buildup is in the liver. It also gives you a 2D map of the stiffness of the liver, and that's what's showing here. So as it gets more and more towards the red, that means it's stiffer and stiffer. So say somebody may have patchy amounts of scar tissue in the liver, an MRI can give you a more holistic view of how much scar tissue there is, whereas a FibroScan will really only give you an assessment of that one area that you assess by the ultrasound probe. This is less impacted by BMI, so it's a good test to order in patients who have elevated BMI or if you have more active inflammation. But again, it's more expensive and there's less access for this. So as I said, super exciting time because we now have 2 different FDA-approved therapies for people who have fatty liver disease, and there's a ton of research going on. So lots of different clinical trials enrolling patients. And so this figure here is just really highlighting what are all the different medications and pathways that we're evaluating that potentially in the future, in addition to the 2 medications we have, maybe multiple different treatment options for patients. Again, I won't go into the details, but just for you to be aware, lots of active research in this space, and as you know, we go through the next few years, I suspect we'll have a lot of different treatment options to offer patients. But there are 2 currently approved FDA treatment options for fatty liver disease. The initial one that was approved is something called resmetirom or Resdifra. And so this was approved based off of a phase 3 clinical trial. This medication is a thyroid hormone receptor agonist, and its activity is specific to the liver. And so the reason that they think this works is, you know, the thyroid hormone receptor in the liver is involved in kind of mobilization of different fats in the liver. And so that's why they think it's helpful in this condition. And so this is the data from that trial that again led to it being approved for fatty liver disease. So they compared people on placebo or no treatment, people on 80 milligrams of the medication, and then people on 100 milligrams of the medication. And in all of the clinical trials for fatty liver disease, they look at 2 different outcomes. So outcome number 1 is, do you have resolution of MASH? This says NASH because it was published before we changed the terminology. So do you have resolution of the liver cell damage, inflammation, without worsening of the amount of scarring? Okay. And then the second outcome, and again, the one that we're really interested in, is do you have improvement in the amount of scarring of the liver without worsening of the MASH? And so here what you can see is when they looked at this, there was a significantly higher number of patients who had improvement in MASH without worsening of scarring. So 26% in the 80 milligrams, 30% in the 100 milligrams, and also a significantly higher number of patients who had improvement in scarring. So 24.2 and essentially 26%. So this is an available treatment for patients with fatty liver disease, but the important thing to know is it is only approved for patients who have stage 2 to 3 scarring, okay? So if you don't have any scarring, so either 0 or 1, you don't qualify, or if you've already progressed to the point of having cirrhosis, you also are not eligible for this medication. And that same holds true for the next medication I'll go over. But if you're in that sweet spot where you have stage 2 to 3 scarring, then you are eligible for this medication. So the second medication I'm sure you have all heard of is semaglutide, which is more commonly known as Wegovy or Ozempic. And so this is the data from this clinical trial looking at it specifically in MASH. The important thing to know, so unlike resmetirom or Resdifra, that is not a weight loss medication. So that we do not see a clinically significant decrease in weight in people who are prescribed that. Unlike semaglutide, as you can imagine, because it is used for weight loss, in the studies of MASH, you can see that on average, the weight loss in people in the treatment arm was 10.5%, whereas it was negative 2% in the placebo. So you get weight loss, which obviously if you have metabolic syndrome, there are multiple benefits from that perspective. But from a liver-specific perspective, again, the 2 outcomes that we look at here, so resolution of MASH without worsening of scarring, it was actually 63% compared to 34%. And then if you're looking at improvement in scarring, it was 36.8% compared to 22.4%. So this was the second medication that was approved, again, only if you have stage 2 to 3 scarring, so not if you don't have any, and not if you have cirrhosis specifically. The key challenge here, you know, unlike Resdifra or resmetirom, who generally speaking is very well tolerated, minimal side effects, I didn't show you that specific data, but the problem with kind of incretin therapy or GLP-1 therapy is depending on the patient, they may have a lot of side effects, particularly GI side effects. And so this is kind of the report of different side effects that patients had. The other important thing to know here is obviously this medication has a lot of different reasons to be prescribed. So diabetes, sleep apnea, weight loss. For this to be used specifically in fatty liver, you have to get to the specific dose that they saw the effect. And a lot of people are using it for other reasons at a lower dose. So it's unclear if they'll also get the liver-related benefit if you don't actually get to the dose that it was used in this trial, which was 2.4 milligrams. So to kind of put it all together, because I went over a lot of different things, and again, I know that this is a very broad audience, but if you're thinking about who do we need to screen, how do we risk stratify them, who's eligible for these new treatments, and how do I follow them? So again, step one, who do I need to be screening, who is at risk for this? So essentially, if you have any cardiometabolic risk factors, and then again, the two other common reasons are if you were noted to have fat buildup on imaging, or if you have elevated liver enzymes. Okay, you've identified who you need to screen. How do you screen them? Again, FIB4. FIB4 is just based off of very easy to obtain blood tests. So essentially you use platelet count, liver enzymes, and we use your age, puts you into one of three buckets: low, medium, or high risk. Anyone with low risk stays with primary care doctor. Anyone with indeterminate or high either goes straight to GI or liver referral, or can go on to the secondary test. The secondary test is either that FibroScan or VCTE, which is that fancy ultrasound that measures the liver stiffness, or if you don't have access to that, you can do this blood test called an ELF. Again, same concept: low, medium, or high risk. Low risk stays with primary care, intermediate to high. If it's high risk, then the subspecialist, the GI or liver person, has to figure out, okay, does this person potentially have cirrhosis? If so, then kind of focusing on that. And if not, again, trying to figure out, is this a person who potentially is eligible for one of our two treatments, resmetirom or semaglutide? If they are, then essentially we start them on the therapy and we monitor them over time. We monitor patients usually through blood work, so we're monitoring liver enzymes, or we do a repeat FibroScan, which is that ultrasound to see if they're responding. And then I'll get into, say you are not eligible for treatment, what is our kind of core treatment for all patients with fatty liver disease, irrespective of whether or not you're eligible for these new medications. I will not go into this, but it's a super exciting time. Lots of different medications and different phases of evaluations. This is just highlighting some of them. In the event that you were super interested and you wanted to read up on them, we don't have data from these trials as of yet, but we're hoping soon we'll have some additional treatment agents to offer people. So as I said, there are core tenets of treatment for anyone with fatty liver disease, irrespective of whether or not they're eligible for pharmacotherapy or these new medications. The key thing that you've probably heard is the importance of weight loss. And I'll get into some of the nuances of this, but this comes from kind of this main study back in 2017, actually, where they enrolled patients with fatty liver disease, did 52 weeks of a lifestyle intervention, so focusing on healthy nutrition, exercise, and weight loss. And the numbers that you'll hear are these numbers. So if you achieve 5% weight loss and you maintain that amount of weight loss, we see improvement in the amount of fat buildup in the liver. If you get to 7% of weight loss, you see improvements in fat buildup and also inflammation. But the key percentage number that you'll always hear is 10%. If you get to 10% weight loss and you keep that amount off, you get improvement in steatosis, so fat buildup, improvement in inflammation, and actually improvement in the amount of scarring. So the key thing that we always like to focus on with patients is if we catch this early enough, it's completely reversible. The issue is, again, people will not present until they get to cirrhosis with end-stage liver disease, at which point, there's a lot of discussion about whether or not any of that is reversible. But essentially, if it's before cirrhosis, this condition can be reversed. Again, the challenge is finding patients early enough so that we can still have it be reversed. But 10% is, classically speaking, the number that we say amount of weight loss that will lead to reversal of scarring of the liver. As I said, it's more complicated than just weight alone. There is something called lean MASLD, meaning even if your body mass index is not elevated, up to 20% of people can still have fatty liver disease. And why is that? It's because it's not just what your weight is, but it's where you're hanging on to the fat. So whether it's subcutaneous, meaning just under the skin, that is not putting you at risk necessarily for fatty liver disease, but if you are somebody who tends to deposit fat in the organs, that's what we worry about. And again, that's not being directly captured by your weight. We also know BMI has tons of different limitations. Somebody who has a very high amount of muscle mass, so like athletes, people who are very physically active, your total weight and BMI thereby would be high, but that doesn't necessarily translate to your risk of having fatty liver disease. So then again, weight loss we always spend a lot of time talking about. Nutrition is key though. So people want to know, okay, what are the things that I'm eating that are increasing my risk of having fatty liver disease? What are the changes I can make to my diet that will decrease my likelihood of having progression of liver disease and potentially help me reverse this? So the things that we know very clearly are associated with risk of fatty liver disease is a high amount of carbohydrate intake, because this promotes fat buildup in general. Even in the absence of gaining weight, people who have a high amount of carbohydrate intake have higher risk of fatty liver disease. High fructose corn syrup is a huge problem, and we know very clearly is associated with risk of fatty liver disease, as is high amounts of red and processed meats, high dietary fats, specifically saturated fatty acids, and then a high total caloric intake. Again, I think total calories is less important than really the types of food that you're eating, but there is some data to show that your overall amount of calories does track with risk of fatty liver disease. And these figures here just essentially show that. So when they've done studies looking at self-reported amount of carbohydrates from soft drinks and red and processed meats, those who had higher amounts had higher risk of fatty liver disease. And then this other figure shows the amount of saturated fatty acids and how that tracks with higher likelihood of having fatty liver disease. So what do we recommend? So the two diets that have the most evidence for treatment of fatty liver disease are either a low carbohydrate versus low fat. A lot of patients who have type 2 diabetes are already following a low carbohydrate diet, and so we recommend that they continue on that type of dietary pattern. But there's a ton of data and interest in Mediterranean diet. So we spend a lot of time going over this with patients. The key thing for you to know is, depending on what literature you're giving patients, it may sometimes highlight the importance of having regular red wine intake, which we do not recommend. So just be mindful depending on what you're, where you're getting your literature from and what handouts you're giving people. The other important thing is physical activity. So we know that those individuals that have more regular physical activity have a lower likelihood of having fatty liver disease. And the key thing I like to highlight is, even in the absence of weight loss, people who exercise or are more physically active have less fat in the liver. So people will start an exercise program and they won't lose weight, and they'll get very frustrated and want to stop their exercise program. And it's really important to emphasize, even if you're not seeing the weight loss, we know from these studies, people who are more physically active have less fat in the liver, so it's important to encourage them to continue to be physically active. People want to know what type of exercise is most helpful. This is a hard question to answer, but there is some data to show that aerobic exercise is maybe more effective than resistance. But again, you have to tailor it to what, one, people are interested in, and two, what people can do. Particularly as individuals get older, they may not be able to do kind of more intensive aerobic exercise. In that case, resistance exercise is still useful. There's some data to show that more vigorous exercise is helpful, and if you do it more often, same thing. But again, depending on where you're starting from, you would just want to, in general, encourage more physical activity. This is just data showing that people who are more physically active had both less fat in the liver and less rates of fatty liver disease. The other question that comes up a lot is, should I be thinking about bariatric surgery if I have fatty liver disease? And then there's kind of a growing a number of people who are doing something called endobariatrics, which technically isn't a surgery, but through endoscopy, so through specialized GI providers, potentially you can have weight loss intervention. So bariatric surgery is not specifically recommended as a treatment for MASLD or MASH, but a lot of patients who have MASLD or MASH otherwise qualify. So if you otherwise meet criteria for this and it's something that you're interested in, there is good data showing that when they've done repeat biopsies in these individuals, we see significant improvement in their liver disease. Same thing for endobariatrics, again, a much smaller field, but there is good data to show that if you undergo this type of procedure and you lose weight, then your liver disease improves. So just as we're getting to the end of our time here, what are the unmet needs and future directions? So huge problem. Now we have these screening recommendations, risk stratification, treatments. We know in the community and in rural practice it's not happening. A lot of that is because, you know, primary care doctors are very overburdened. They don't have the time, the support to do this. Patients have their own competing priorities. There's a lot of disease awareness challenges. So we really need to work on ways to really get people to know about this disease, to get screened for the disease, and to get risk stratified. There's still issues in terms of access to secondary testing. As I said, the FibroScan, access to subspecialty care. So say you do all of the screening and risk stratification and they need to see a GI liver specialist, maybe you don't have access to that where you are. As I said, we have these new treatments. We've shown that it improves amount of fat, inflammation, and scarring. but we need longer term studies to show that at the end of the day, it improves liver related outcomes. So progression to cirrhosis, need for transplant, liver related death. There are no current treatments that are approved in cirrhosis, so that's a huge unmet need. There's a lot of research going on. We're hopeful that some of these medications may be approved for patients with cirrhosis, but that's a huge problem. I talked a lot about the high burden in San Diego and in Hispanic populations, so we really need a lot of resources and interventions to try and reduce this disparity in terms of, why is it so much more prevalent in these populations. And then there's a lot of interest in kind of what we call precision medicine. So there's genetic risk factors for this disease, so tailoring screening, treatment, specifically based off of your individual risk factors. So to summarize, MASLD is common. 1 in 3 adults in the United States has it, and it's usually asymptomatic. Most patients are not screened for this condition. Individuals with cardiometabolic risk factors should be screened. Awareness and early screening can really save lives in our community, and we need to do a much better job about doing this. FIB-4 scores from routine blood tests is the initial risk stratification test to identify who needs further evaluation. Because again, the vast majority of patients with MASLD are low risk, don't eventually progress to end-stage liver disease, so we need to use a FIB-4 as our initial test to figure out who needs additional testing. Super important now that we have these treatments still to remember that healthy lifestyle is recommended for all patients with MASLD, and that 10% weight loss can improve fibrosis. So super important to highlight that this is a reversible condition so long as we detect it early enough on. We do now, very excitingly, have 2 different FDA-approved treatments for MASH. We don't have anything for cirrhosis, but the future of MASH therapy is bright. There are tons of studies underway, and I'm hopeful in the next few years we'll have even more treatments available to offer to patients. So on that, I will close. I will thank you very much, particularly for staying on after normal business hours to listen to me talk. If you have any questions, this is my information, my personal email or research center email. If you're active on X, you're welcome to follow with myself and our research center. If you or anyone you know is interested in participating in clinical research, whether it's clinical trials or other research, this is our link to actively enrolling trials. And with that, I will close.
Thank you so much for that very informative, informational talk. As we transition into our panelists for this evening for our fatty liver disease, we have Dr. Sayone T. We also have Dr. Wayne Ho, Marlissa Herring, and of course, Dr. Mónica Tincopa. So we'll start first with Dr. Sayone.
Thank you, Chaplain, and thank you, Dr. Mónica, for that wonderful presentation. Very comprehensive, and actually, I know we're a little limited on time, so I'm just gonna hit the highlights of some of the things. Just really re-emphasizing a lot of what Mónica you just spoke about. But I'm just pulling up my slide. Sorry. And then share some data, just countywide data. So my name's Sayone. I'm your public health officer. I apologize. I'm at home and kids are rowdy upstairs, so hopefully it's not loud, but I'm happy to share a PDF of these slides. I just wanted to share, trying to advance. There we go. Okay, so you could see this, right? Sounds like, okay. So, we spend a lot of time in the clinical world really thinking about, as you see here, and I don't know if you can see my mouse or not, where it says disease and injury in healthcare, and right when people are seeing folks in the healthcare setting often, and we're seeing the end results of a lot of the really upstream factors that are impacting and or mitigating right some of the things that are seen in a healthcare environment. So I really appreciate that Dr. Tincopa looked and talked about things really upstream, and that's our role as public health. And public health is all of us, right? It's not just the health department. A lot of you all are public health champions, and just by being here and listening to this. And so we know that we not only have to address people in the individual clinical setting, but also the risk behaviors, their living conditions, all these inequities that we're talking about. And these are upstream things. And so when we talk about health, we're not just talking about physical health, or behavioral health, but really these upstream contributors or drivers of health as well. And then, I know we talked a lot about that. Some things, they just wanted to share some county-wide data. There is a California Health Interview Survey that we pay to sample and at a level that we can get a reliable estimate. And this is self-reported data, but our latest data, and you see here trends of how many people are self-reporting things like being diagnosed with diabetes. We know, of course, there are people who are undiagnosed, but we know these are risk factors. And so you see this like 8%. Nationally, it's usually around 8-9%, if I remember correctly. But then when you look at serological testing, it's more like 11 or something there, because there's a decent amount of people who undiagnosed diabetes with blood pressure or high blood pressure in adults. You see these numbers, and I know they vary a lot. Again, it's self-reported, but you see about a quarter of people are saying that they're self-diagnosed, that they're diagnosed with high blood pressure in San Diego County when we look at our latest data. And then, of course, we have death-related data, which is probably the most complete data set if you think of all the data that we have at the county, right? Because everyone is born and everyone dies, unfortunately. And so we do get all of those records. And so I'm not going to go through, just because of time, all these data, but just so you see where we are, where things are trending, not just the number of deaths, but the rates, and then how it compares to healthy people 2030 federal target. So you see, and I also want to say that in addition to chronic liver disease, for example, deaths, not just by numbers and rates, here you see by race, ethnicity, and we do have other ways, of course, by looking at things from equity and different lenses of equity, geography, age, sexual identity and orientation, things like that, and gender, and I don't have that here, but I just wanted to share at least race, ethnicity with you all to see and highlight some of these disparities. When we look at primary hypertension, for example, we see these numbers and rates, and then you see a significant disparity, just with African Americans, really in that green line at the top, with the significant kind of space between their rate and other rates they see here. I will note Native Americans are not on here, likely because our numbers are too small, but usually they're very disparate in terms of the numbers as well. And then diabetes deaths, and here also same thing with age-adjusted rates, and you see again that African Americans significantly higher, age-adjusted rates. And then these are, the upstream things we've talked about it. Obviously, easier said than done, or else we would all, I think as a nation, we would all be much healthier. But we know it's not just the individual level, but it also does include the individual level and individual points of decisions. But we know some of that can be easier or harder depending on the environments that we are, depending on our stress levels, depending on our economic situations, depending on other factors. And so I like this image just because it not only talks about what individuals can do, but also what we could do as organizations, just in terms of systems, policy, and environmental change. And I'm not going to read each one, but things just for, I know we're mostly talking about the top left, the non-communicable or chronic disease. But so I'll read those: invest in safe parks and recreational facilities, right? Allow the environments for people to thrive and be healthy, both for their physical and mental health. Increase the availability and affordability of fresh produce. And this is a time actually where people, very low income people, are losing CalFresh or having a harder time staying on CalFresh, for example, which is food stamps or SNAP at the national level, because of changes in Medicaid or Medi-Cal that are being introduced in California. And then encourage healthy behaviors and adopt walkable communities, right? How do we make the healthy choice the default choice? What are those policy systems, environmental change that complement people's individual autonomy and ability to be healthy? And then I will skip over this, but there's a whole bunch of things that if anyone wants to join the Live Well San Diego kind of movement, if you will, or the vision of being healthy, living healthy, safe, and thriving, there are ways that you can do that. There's a huge county, as you know, we have multiple regions, the kind of that we break the county up into, and we have community leadership teams where you can be a partner, you can join certain sectors, and we can challenge each other because we have a lot of challenges that we do throughout the year. So I will stop there and yield my time. But again, I'm happy to share these slides after. Back to you, Chaplain.
There we go. Thank you so much, Dr. Sayone. I appreciate you being the County of San Diego Public Health Officer. The county has I have a love for the county. I really do. Next, we're going to move forward with Dr. Wayne Ho. He's a medical and research director of Atlas Immunometabolic Health and Research. Dr. Ho, if you would.
Hi, everyone. I'm going to talk about prevention. And as a clinician, researcher, and advocate in the area of diabetes and obesity, I really think we should focus on the M in MASLD and MASH for prevention. Um, Excess fat is the most common cause of metabolic dysfunction and insulin resistance. So let's focus on decreasing fat through weight loss to improve liver health. Can we get my slide up by chance? No, that's okay. If we can't get it, I'll just continue. So, um, as Dr. Tincopa had said, losing 5% is sort of the minimum number to improve. 5% of your body weight is the minimum number to improve liver health, with really our goal of 10% or more. So we can achieve this through all the lifestyle improvement changes that Dr. Tincopa outlined, as well as medication or combination of both of those. Uh, and just to review very quickly, lifestyle changes include improving your diet quality, looking at how much ultra-processed foods you're eating, foods high in saturated fat and sugars, um, and also decreasing alcohol consumption. All of that makes an impact on weight. So I think that is a place to start. And as also Dr. Tincopa said, exercise decreases the amount of visceral fat, which is the fat that is the highest risk for metabolic dysfunction. So more physical activity is great. Can we move on? Next slide, please. All right. As for medications, the GLP-1 class of medications has revolutionized how we treat diabetes and obesity. But unfortunately, Medi-Cal has cut coverage for GLP-1 medications for the treatment of obesity starting at the beginning of this year. And sadly, that really just removes access for a large population that is at most, which is the most at risk and vulnerable to MASLD and MASH. So we are strongly advocating that Sacramento reverse this decision, but in the meantime, know that GLP-1s are still covered for the treatment of type 2 diabetes. But on to a more positive note. As Dr. Tincopa said, in 2025, semaglutide, also known as Wegovy, became the first GLP-1 medication FDA approved for both the indication of obesity and MASH with moderate to advanced fibrosis. Medi-Cal started covering semaglutide for the indication of MASH without prior authorization starting in April of this year. That restores access to semaglutide for some of our patients that carry the diagnosis codes of MASH, as well as fatty changes of the liver per Medi-Cal guidelines. Semaglutide prescribed only for the treatment of obesity, again, is still not covered by Medi-Cal, unfortunately. But for more positive news, there are promising treatments on the horizon for obesity and MASH. And to go in a little bit more detail, these medications combine GLP with another component called glucagon agonism. And two of the most promising medications are survodutide and retatrutide. Survodutide, just recently, there was a survodutide study that was just published last week at the American Diabetes Association conference that showed liver fat normalization in 63% of their participants. And for retatrutide, they had a similar study that showed liver fat normalization in up to 93% of their participants. And while we may not see those rates in the real world if these medications do get approved, it's still very exciting. So stay tuned for that. So in conclusion, we all have the power to improve liver health by promoting improved diet quality and improved physical activity in our homes as well as our communities. And particularly in California, we can also appeal to our local representatives to reverse the Medi-Cal decision to end coverage and bring that back for GLP coverage for the for the treatment of obesity. Thank you.
Thank you so much, Dr. Ho, for that information. Our last panelist this evening is Marlissa Herring. She's the co-founder and CEO of Fit, Black, and Educated. And the question that I'd like to ask is, what can patients, families, clinicians, and community leaders do to confront the growing burden of fatty liver disease?
Hi, Chaplain. Thank you for that question. So one of the things that with my organization, Fit Black and Educated, that we have done is we believe that making these things visible and accessible. So yes, we can talk about them all day long. Our physicians can tell us about them, but unless you actually see it in action and have that community to support you and have that accountability, a lot of people don't continue on. So when you connect that aspect of taking care of your health, having a community to support you and hold you accountable, that helps in that prevention. So we have I look at it this way, our healthcare providers, they're essential for, diagnosis and treatment of diseases, but community organizations, those are the ones that play that critical role in prevention. And by creating environments where there's healthy choices that become normalized and supported and sustainable. So it's a great combination between everything, and it works in combination so that we can help prevent certain diseases, including fatty liver disease. So, and we've done some things, whereas we've created, 5Ks, hiking, just to get people active and moving. And that's across the board. So in San Diego, there are a lot of run organizations. You have Santa Mujeres, you have Black Men Run, Black Girls Run, you have Urban Run. You have all these run groups now that are popping up and coming together to help improving the health of their communities and getting people active. So you don't necessarily have to do this big jump of, I have to lift heavy, I have to, do extreme things. Really, it's just starting with the small part. Take a walk, go to your community garden for education, or even create a community garden. I know in LA, they have LA Crop Swap. And whereas they're turning their front yards into gardens. And then they're taking that and they're sharing their produce with their neighbors. So it can even just start with that small thing. It doesn't always have to be the government coming in and doing something. We can do something with one another as organizations and as neighbors.
Thank you so much for that. That is wonderful, for giving us all of that information. So as we come to a close, Global Fatty Liver Day is more than a date on a calendar. It is a movement dedicated in ensuring that no one suffers from preventable liver disease because they lack information, access, or support. Awareness must lead to action. Action leads to prevention, and prevention saves lives. So whether you are a patient, a caregiver, a healthcare professional, a community advocate, each one of us have a role to play in improving liver health. On behalf of the Liver Coalition of San Diego, thank you to our distinguished panelists, our attendees, and everyone working to increase awareness and improve outcomes for those affected by liver disease. Thank you, thank you, thank you for joining us in recognizing Global Fatty Liver Day and helping us build healthier communities through education, advocacy, and hope. Together, we can turn awareness into action and improve the health of our communities. Thank you again and have a wonderful evening.
And if we could get everyone's final thought as we exit the room on what's one thing that you want everyone to do tomorrow because of what you learned today.
Let's start with Dr. Tincopa, since you led us into this beautiful discussion tonight.
Sure. I will lead with just really emphasizing how important it is, again, for everyone, whether you have fatty liver disease or not. This is all driven kind of on lifestyle behaviors, lifestyle options. So really, whatever is in your power to try and do the best you can to have healthy nutrition, to move your body, and to really be proactive in terms of trying to do things that not only are healthy for your liver, but for your overall lifestyle, I think is the key thing.
Perfect. Dr.
Mhm.
Sayone.
Thank you. And so I would just say, in addition to what already was said, is really just to share this wonderful information that we've all received, and I even learned too a lot. And so I think we all have a lot of influence. And even though we see in health surveys that in terms of health and trust, that people trust that maybe their doctors and nurses most, we know that people don't always see their providers often, and then usually they're more around their friends and family and other folks. And then some of you who are here and listening are in the medical and health arena or CBO arena or faith-based arena, and you're able to influence others in your circles and just share fact-based data like you heard today.
Great. Dr. Ho?
I think tomorrow we should all do one thing to make our environment make us more successful. The example I'd love to give is if you look on your kitchen counter, there may be cookies, there may be chips, and taking those and putting them on the lowest shelf or the highest shelf that you have will make you think before you reach for them, and then replace them with things that are healthier, maybe some fruits that you can eat. And the more accessible they are, the more successful you become because they're just easier to grab. On a community level, I think we can do something similar. We can create environments that are conducive to more physical activity, biking, walking, and also if we have community leaders listening, bringing in healthier foods to our food deserts. So that's my hope.
Wonderful. And last but not least, Miss Marlissa.
I would say there are a couple of things you could do tomorrow. One, I would definitely share the information that we've learned here today, and then grab your closest friend or family member and schedule a doctor's appointment. Go get screened. So, and then also visit your local garden. There's plenty of community gardens in Southeast San Diego as well. Go visit them. They have produce, or just learn how to garden so you can start your own at home.
That's wonderful. Thank you all for the information. Thank you so much for joining us on this evening, and we look forward to speaking again.